Ladies and gentlemen, good morning everybody. We are going to talk today about short and long-term acute coronary syndrome mortality in Middle East, in particular Arabian Gulf countries. This is Khalid Al-Nimr, clinical professor of cardiology, Saudi Arabia, Riyadh, head of cardiology in Al-Habib Ulayya Medical Center. First of all, I have to clearly declare that there is no conflict of interest related to this presentation. Now, what we're going to talk today about, we have different outlines. First, we're going to talk about the result of short and relatively long-term mortality in acute coronary syndrome in the Gulf area. Then we're going to talk about factors that could affect the results. Then we're gonna shed some light on the areas of challenges and areas of improvement, in particular related to acute coronary syndrome mortality data from the Gulf area, and what is our conclusion. Now, as you know, now there is several reports before of acute coronary syndrome data. Mostly it was single center experience or multiple centers, which limited number of centers. But the largest number we have was in Gulf Race 1 and Gulf Race 2. In Gulf Race 1, Saudi Arabia was not involved. In Gulf Race 2, Saudi Arabia was involved in the follow-up. Now, in Gulf Race 2, there was around 7,500 patients collected over the period from October 2008 to June 2009, and it was spread 66 centers spread all over the 6 countries. Now you have to understand that the number of those centers represent less than 20% of the total numbers of hospitals treat acute coronary syndrome. Why is that? Because the involvement in that registry was voluntary, i.e. you propose the project to different hospitals and you see who respond and you involve them in the study. So this fact in particular has an impact on the data we're going to present. The mean age of the patients was 56, which is relatively younger than what is reported in other registries in the world. 80% were male, around 80% also were citizens of that country, and 65% of them they received the concurrent evidence-based medicine combination at discharge. This is relatively lower than what we expect and what is reported in other registries. Now, if we want to talk about, for example, at discharge, there was only 70% of the patients were on aspirin and clopidogrel on discharge from the hospital. So this is relatively lower than the benchmark of the 90% you expect on discharge. Now, an interesting fact, as reported by Zakwani and others from the Gulf Race Registry, that there was no difference between evidence-based medicine use and not use on discharge on 1 month or 1 year mortality. And the mortality rate was relatively low, around 3% to 3.5%, users versus non-users of evidence-based medicine. Certainly, this is lower. The evidence-based medicine use was reported to be higher in other registry and impact on mortality. For example, in Grace Registry, it was shown very clearly that when you are on all the 4 indicated evidence-based medications, this has a significant impact on 2-year survival compared to people who received one or less than one evidence-based medication. Why is that? Why there is why the use of evidence-based medicine in the Gulf race did not show a difference in mortality? This is simply for several reasons. Number one, the loss, first of all, because of the selection bias. Since the involvement of the hospitals was voluntary, certainly this will impact on the quality of data we have. 80% of the Ministry of Health hospitals in Saudi Arabia was not involved in the registry we have. And the second issue is the sequential catchment of acute coronary syndrome in that registry was not detected very accurately to prevent the loss of cases, and that's why the data came lower than what is expected in other registries. Now this is a challenge, this is an opportunity to set more effective future registries and to involve more hospitals and to have more strict mechanism on capturing the sequential detection of acute coronary syndrome cases in the emergency room. Now, if we see that the profile of the patients, we found that around 47% of them has hypertension, 32% has dyslipidemia. Diabetes detection was around 40%. So we have a high risk population involved with diabetes, hypertension, dyslipidemia. In addition, they will also have poor lifestyle. The smoking rate was 35%. Sedentary life was not reported in this registry, but in other studies the sedentary life was more than 80%, as reported by Nuzha and et al., other people. The interquartile range of coming from the symptoms to the emergency room was 210 minutes. This is a really long time compared to other registries. If you see the data reported by other authors on the same registries, the mortality rate was almost double. The 30 days mortality was 7% compared to the other papers. Zekwani reported 3%, and also the other the 1 year mortality 9.4% compared to Zekwani reported around 3.8%. Certainly this is from the same registries with two different mortality numbers from two authors. This indicates that maybe the purity of the data need to be recleaned again and studied and distributed equally between different authors. At the same time, more set future registries has to be done more accurately to involve more numbers and more hospitals and more detection of acute coronary syndrome cases. The same story happening in the mortality data, the difference between the two studies reported from the Gulf registry. Now, we did a published study on diabetes in acute coronary syndrome in Saudi Arabia, and we have published it in 2012. We showed that around 58% of all acute coronary syndrome patients, they have diabetes. This is higher than what is reported in EuroHeart, higher than what's reported in GRACE, CREATE, and Gulf race registries too, indicating probably we are dealing with a high risk population and we need more accurate detection of the in-hospital and short-term and long-term mortality data. In the SPACE registry, SPACE diabetes registry, our mortality, in-hospital mortality was in the range of 3 to 3.5%, diabetic versus non-diabetic, as is shown in the figure. And certainly the mortality goes with the more sicker patients you have and more cardiac complications they have. This is a slide which can explain the disproportionate mortality risk ratio, i.e. in Gulf areas, Gulf countries, we have high risk population, diabetic, hypertensive, dyslipidemia, high risk of smoking, high risk of sedentary life. On the other hand, we don't have proportionate mortality data of acute coronary syndrome. The reasons, we already spoke about them, and those reasons in the future would need to be avoided and have more strict data, more involvement of centers, more involvement of patients to avoid the selection bias we had in the previous data. Now, we learned that from the registries we have in Gulf that acute coronary syndrome patients present at relatively younger age, and they have higher rate of diabetes, and STEMI patients present usually late to the emergency room, either from the symptoms to the door time or from door time to needle time for thrombolysis, and usually the median time is more than 30 minutes. The people who come to with the window time was less than 30%, and the use of thrombolytics was in 70% of the cases, and the use of primary PCI was much lower than what is reported in the world, because 24 hours PCI in Gulf countries still lagging behind. From the whole registry, we have only around 4% which fulfill these data. Now, what is the areas of challenges in acute coronary syndrome management in Saudi Arabia? Well, we have 4 challenges. If we know them very well, then we can avoid them, we can find a pathway of improving our acute coronary syndrome mortality in future. Number 1, no established effective national protocol and guidelines to control the standards of acute coronary syndrome in Saudi Arabia in the management, whether in the government or private sector. Number 2, the interventional cath labs in the country, they are not 24/7 performance, all of them in particular. It's voluntary whether you want to do it or you don't do it. I think we should have more strict mechanism based on geographic areas. We should have centers where perform 24/7 per capita according to the number of the population they have. Emergency medical services, transportation are not given a priority, and lack of resources, and public education to use them also is lagging behind. We did a study recently, a questionnaire format on 25,000 persons, asking them in Saudi Arabia, if we have a heart attack, would you go directly to the hospital by your car or your friend's car, or use the emergency medical services? And 90% of them answered they would go by their own car to the hospital, indicating still the emergency medical services in 2013 did not improve a lot from 2009. Maybe the public understanding of the importance need to be changed in near future. The fourth important issue is the low level of acute coronary syndrome patient education. We did a study and we found 80% of people with coronary artery disease in Saudi Arabia, they have elementary or below elementary level of education. Now, areas of improvement, we need well-structured acute coronary syndrome registry in the Middle East and involved in more other countries. We need to avoid the issues affected the previous registries, are the selection bias, sequential catchment of acute coronary syndrome cases in the emergency room. We need better assessment for evidence-based medicine use and education of the patients. We need help on the local healthcare system to achieve quality performance and to do percentile performance for hospitals to see if this has changed in the last 6 months or so. We need a campaign on public and professional education seminars to people to let them know the importance of cardiovascular disease and acute coronary syndrome, and need for more effective medications to improve the long-term mortality and morbidity in acute coronary syndrome. So the conclusion is, in Gulf country there is a high-risk acute coronary syndrome population with a high prevalence of risk factor and poor lifestyle, and there is challenges in the timing to present to the hospital and rate of revascularization and use of evidence-based medication. The second important conclusion is there is a great opportunity in the Gulf area for more future inclusive research and better organization research for medical intervention on pharmacological and non-pharmacological measures. Thank you for listening, and we'll see you soon. The answer is simply multi-level to answer the problem, because this is a final point, which is the mortality, short-term and long mortality. So if you want to lower it, you should have intervention in multiple sectors. First of all, at the level of the patient. So when you have a heart attack, you should use the emergency medical services in the Gulf area, and when you use your aspirin, and educate them on the importance of the medications and importance of calling the emergency medical services. Another level of education is before discharge. There is poor compliance of poor level to attachment of evidence-based medication on discharge in the Gulf areas. That's why we need to educate both the patient and the professionals. Number two, at the level of the emergency medical services, the digital system, catchment of the patient, taking them quickly to the emergency room. The third level, at the level of the hospitals, where they provide the 24 hours 7 PCI slash thrombolysis if they couldn't, but within the allotted time and acceptable performance time all over the world. The other importance issue, we need more data from the Gulf area, more vigorous, involving more centers, and avoid the selection bias and sequential catchment of patients. So to build them on the in the short and long-term future and compare it to the previous data we have. The last issue is we need more medication, more effective medications to lower the mortality in acute coronary syndrome. Obviously what we have is not enough, so we need on the board several others, antithrombotic and other medications and intervention to lower the acute coronary syndrome mortality. And you can see in the market there is more medications coming, more powerful than aspirin and Plavix. But in the Gulf countries we need more data, whether it's registries as experienced with the new medications, and see the difference we had compared to the previous 5 to 6 years.